Good afternoon, and many thanks to the ICS committee for this opportunity. I have no disclosures. So as already mentioned in previous talks, the use of mid-urethral slings to treat stress urinary incontinence has dwindled down to the sort of safety concerns that have recently come out. Patients who do develop complications as a result of mid-urethral slings can be a difficult group to manage, and this field generally is still a relatively new subspecialty. With that in mind, we compiled a cohort of patients who had developed complications in our centre to share our experience and outcomes of managing these patients. So the cohort was put together retrospectively using a prospectively maintained database over a 7.5-year period from 2012 till mid-2019. In total, we identified 62 female patients, and they had a mean age of 63, mean BMI of 30.1, and a mean ASA of 2.1. We observed that the median length of time between mesh insertion and subsequent removal was in the order of 9 years. Looking at some preoperative data, we noted that the most common presenting complaint was that of pain, and that accounted for 35% of our cohort. 72% of the patients had tape exposure, and the vagina was the most common site of exposure. Moving on to the salvage procedures performed. So using the IUGA definition that was presented yesterday, about 66% of our patients had complete mesh removal, 16% had a radical mesh removal, a similar percentage had partial removal, and a small percentage had revision surgery. Postoperatively, we noted that where the chief complaint was pain, 14 out of the 15 patients had at least an improvement in their pain levels. However, a significant proportion of patients did develop incontinence, with 25% of patients requiring recurrent stress urinary incontinence procedures, and a further 22% requiring a further procedure for unmasked urge urinary incontinence. This graph shows the cumulative procedures performed over time, and you can see that sort of since 2017, our workload and volume has increased quite significantly. So to conclude, mesh-related complications, as we've already heard, are a rising problem. Patients generally present with a wide variety of symptoms, but we've noted that pain is the most common feature. By and large, symptoms do get better following salvage procedures. However, a significant proportion of patients do then develop urinary incontinence and require further procedures, and they need to be counselled for that appropriately in the preoperative setting. And lastly, due to the sort of complex nature of managing these patients, we feel that they're best looked after in high-volume centres. Thank you.
Thank you. The paper is open for discussion.
Again, I congratulate you for a very good study and an ongoing study. 93% improvement or cure of pain, to me, is astronomically high. It's certainly twice or more better than I get, and much better than the rest of the literature. What do you do, and how do you assess the pain?
So we could have been a bit more granular in how we sort of obtain results about pain improvement. We do have validated questionnaires that we use to kind of gauge whether or not pain has improved pre and post-op. The percentage I've used there is based on what we said in our clinic letter when we've reviewed patients down the line. So that figure may be different when we've reviewed the questionnaires in depth to see just how much pain has improved, if at all. But that's a small number. There's only 15 patients there, so it's difficult to draw too many conclusions from that.
Ash Clancy from Ottawa, Canada. You showed a graph showing that there's a cumulatively increasing number of procedures over time, but do you have a sense for the denominator? Like, are more women coming forward to have their mesh removed, or is it just because more TVTs are being done?
So we're getting more referrals. We are seeing more patients in clinic with mesh-related complications, and that correlates with the number of procedures that we're carrying out.
I mean, the initial procedures, are there more of those occurring, or are more women, or like higher proportion of women getting initial, who had TVTs or who had many of these things,
So, I mean,
choosing to have them removed?
in the UK, there's a pause on mesh use, so there's none being carried out in the UK currently. There is this lag time of about 9 years between insertion and subsequent complications. So it's difficult to know, if what the trends are in terms of insertion and complications. I think
It would be interesting to have the baseline denominator.
Yeah, absolutely. Yeah.
Thank you very much.
Thank you.